I'm David Jones. I am a consultant ophthalmologist. That's spelled O-P-H-T-H. Please don't forget that, because anything else you do in ophthalmology depends on you being able to spell my name and what I do for a living. We're going to talk for the next 10 or 15 minutes about retinal diseases. And by the end of it, I hope that you will be able to take a history and know how to examine for retinal diseases and understand a bit about the range of diseases that affect the retina. Before we start, though, we should find out really what the retina is and does. The retina is really just the lining of the back of the eye, which converts light into neural impulses, not too dissimilar to a solar panel. Its structure, as you probably know, is just a multi-layered orange film at the back of the eye, where there are certain structures such as the macula, the fovea, the optic disc, and the retinal vessels. The function of the retina is to turn light into electricity in a complex system of phototransduction. But put very simply, the eye will focus the light on the back of the eye, and the retina will convert it into electricity. And that's the simplicity of the eye, which you should never lose sight of, if you'll excuse the pun. The history that your patients will give if they have retinal diseases are quite straightforward, really. If you have a disorder of the macula, that is to say, the central retina, your patient might complain of distorted vision, where straight lines appear bent. Patients with diffuse dysfunction of the retina, and by that I mean the rods and the cones of the retina, might complain of blurred or dimmed vision. But the hallmark of detached retina is the 3 Fs: flashing lights, floaters, and field loss. If your patient presents with those symptoms, that is a red flag to get them seen as soon as possible by an ophthalmologist. The examination for retinal disease is not as difficult as you think and starts with the letter chart, the Snellen chart. You should take the visual acuity in the way in which we all know how to do. An Amsler chart is a similarly simple test that you can even print off the internet. You present the patient with this grid of squares and ask them to focus on the dot in the middle of the square with the other eye closed or covered. If, while looking at the dot in the middle, there are bent or distorted or missing lines, your patient might well have a macular disorder, as shown on the right-hand image. The examination gets a bit more tricky when we talk about actually looking at the retina, and I know that a lot of you find difficulty in seeing the back of the eye. It is a useful but not essential skill, because we ophthalmologists need something to keep us occupied. So I'm very happy to be referred patients in whom you have not been able to perform fundoscopy. If you are able to use an ophthalmoscope, you can at least get the red reflex. The red reflex implies that the structures of the eye are clear and the retina is red. The picture below shows a child with a white retina due to a tumour, a retinoblastoma. We as ophthalmologists have wonderful toys, and one of my favourite toys, which is what made me want to be an eye doctor, is the binocular indirect ophthalmoscope. This enables you almost to climb inside the eye with three-dimensional reality to see the back of the eye. Fundus cameras mean that you don't even need to look at the back of the eye yourself, and the camera will do that for you. We investigate the retina in a number of different ways, including with an OCT, ocular coherence tomography. This is a laser scanning device which takes a cross-section through the retina. Fluorescein angiography involves injecting dye into the veins and seeing where the fluid goes both in the blood vessels of the retina and also in the intercellular spaces. Electroretinogram just tests the electrical responses of the retina as it converts light into electricity. And an ultrasound scan will get you out of a tight spot if you can't see the retina at all, because there are opacities in front of it. So when we think about the causes of retinal disease, and therefore the range of retinal diseases, I would strongly encourage you to use a systematic way of classifying, and my suggestion is as shown on the screen. So let's start with the 3 eyes, the first of which is I, infective. Infective causes of retinal diseases include viruses, cytomegalovirus, herpes simplex virus, and the very serious progressive outer retinal necrosis, which has a rather embarrassing acronym. But these are diseases that more commonly affect people who are immunocompromised. Bacteria can also affect the back of the eye, and this is a picture of tuberculosis causing retinitis. Fungi and yeast are opportunistic infections which commonly affect patients with immunocompromise or have indwelling catheters such as a long line. And you can see here that Candida not only causes a diffuse fluffiness of the vitreous and the retina, but also discrete septic emboli in the retina. Parasites can affect the retina, and you can see that they crawl underneath the retina and cause those tracks, but also float in the middle of the vitreous, and you can see that little critter on the right-hand picture there. Inflammatory causes of retinal disease, i.e. caused by the patient's own immune system, include sarcoidosis and Behçet's disease. Sarcoidosis is a granulomatous disease causing granulomas such as the top picture there, but also vasculitis as seen on the right-hand picture. We doctors can cause retinal disease. If we prescribe tamoxifen or hydroxychloroquine, we can seriously affect the patient's macular function, sometimes irreversibly. Degenerative causes of retinal detachment of retinal diseases include retinal detachment. This is where a traction on the retina from the vitreous humour causes a tear. That breaks the seal around the retina, fluid gets in through that tear and lifts off the retina. Once the retina is no longer attached to the back of the eye, the patient cannot see. And this is why you need to look out for those 3 F's of retinal detachment. The surgery is quite complicated, but involves removing the fluid from underneath the retina and then pushing the retina against the back of the eye. Dry macular degeneration is the commonest cause of impaired vision in the over 60s and is an untreatable or largely untreatable condition that affects many people at the wrong end of life when they're least able to cope. Wet macular degeneration affects the similar sort of people, namely people in their over 60s, but often occurs suddenly and is characterised by fluid getting underneath the retina and then a sudden hemorrhage causing sudden loss of central vision. Wet macular degeneration is potentially treatable, and the way it's treated is by injecting anti-vascular derived endothelial growth factor, anti-VEGF or Lucentis. Patients have to undergo this every month until the fluid is no longer collecting underneath the retina, but is surprisingly effective, albeit very expensive. Macular holes are what it says on the tin, namely a hole caused in the retina by the vitreous plucking perpendicularly. And you can see a cross-section through the retina in the form of an OCT in the bottom right-hand corner of the slide here. Patients who have had severe or sudden head injuries, such as boxers, Thai kickboxers, people involved in contact sports such as rugby, can get a detached retina whereby the retina comes away at the very edge, a bit like an item of clothing comes away at its seam. And what you can see is a retinal dialysis, which is fixed in a similar way to a retinal detachment. Probably the worst and most emotive form of trauma is child abuse. And it is a sad fact that child abuse is and always will be with us. And the job of the retinal surgeon, but also every doctor in this land, is to ensure that it is picked up as soon as possible and the perpetrator is stopped in their tracks. As ophthalmologists, we are called in to look at suspected cases of abusive trauma to see if there are any hemorrhages at the back of the eye, such as you see in this picture here. There are a number of neoplastic causes of retinal disease, of which the most striking is probably the choroidal melanoma. This has certain overlaps with dermatological diseases, but has certain other genetic and phenotypic features which distinguish it from cutaneous melanomas. Sometimes the melanomas have no pigment at all, such as the picture at the bottom of the screen there. Again, a more sinister and emotive eye tumour, retinal tumour, is the retinoblastoma, because it affects babies and young children. This is why the new babies get 2 eye checks, one on day 1 after birth and one about 6 weeks later in primary care. Retinoblastomas, if left untreated, can become very disfiguring and can lead to death. Another type of retinal tumour includes metastasis, and you can get metastases from most neoplastic diseases. This one is a metastasis from a breast carcinoma. And you can see that this metastasis is close enough to the macula to cause macular symptoms. And so you would pick it up, maybe with an Amsler chart, as well as a Snellen chart. There are a number of disorders that affect the blood supply of the retina, and this is the blood storm, typical of central retinal vein occlusion, which presents with a sudden, painless loss of vision. A central retinal artery occlusion presents with a sudden, painless, subtotal loss of vision. And you can see in the bottom right-hand picture of the screen the actual emboli, which we can only presume in other cerebrovascular diseases. This is one of the many attractive sides of ophthalmology, that we can actually see the disease process. Diabetic retinopathy is well known to all of you, but just to recap, is characterized by the development of new and fragile blood vessels which do not restore the oxygenation of the retina, and this can lead to detachment of the retina and lifelong blindness. Of course, if we pick it up early, we can treat it with laser, and the picture on the left is a picture of fresh laser burns, and the picture on the right is of old laser burns to the retina. Diabetic maculopathy is a separate but related condition also associated with diabetes, but is characterized more by the accumulation of fluid at the macula, as well as loss of blood supply to the macula, and therefore there are more exudates and less new blood vessels. The treatment for diabetic maculopathy includes laser treatment, but also the anti-VEGF injections, which you've seen earlier on in this talk. Retinopathy of prematurity is a retinal vascular disease that affects exclusively children who are born very prematurely, namely those who are born less than 32 weeks of gestation and weigh less than 1.5 kilograms, and they are screened every fortnight until they either need treatment in the form of laser treatment or progress to full maturity. Congenital retinal diseases include the pictures shown on the screen here. Optic nerve hypoplasia can result in lifelong defective vision, but not necessarily. A coloboma is an interesting embryological remnant whereby the retina has not fully zipped up during the first few weeks of gestation and presents with a white defect, usually in the lower part of the retina, and is sometimes associated with other clefting defects. So a number of retinal diseases are inherited, and this is why it's important to take a good family history when you are taking a history for retinal disease. You can see here that this is retinitis pigmentosa, characterized by a waxy pale disc and mid-peripheral pigmentation of the retina. And here is another picture of retinitis pigmentosa on the left, but also some very subtle little white flecks at the macula on the right-hand picture, which is one of Stargardt's disease. Perhaps one of the worst inherited retinal disorders is a condition called Leber's amaurosis, where children tend to be blind within the first 6 months of birth, and they tend to have this characteristic eye poking just to get some kind of stimulation into their eyes. Quite recently, some gene therapy has been developed both in this country in the UK, but also in America, which involves injecting replacement genes underneath the retina and then sealing it so that it does not develop a detached retina, and has some early but very small benefits in terms of restoring some visual perception to patients. But most patients with retinal disease cannot have their eyesight restored, and this is where we need to be physicianly and careful and address patients' needs, fears and concerns with a patient-centered approach. We can direct them towards low vision aids, as you can see on the screen there, and we can signpost our patients to those low vision aids by the statutory services supplied by the county councils, but also the voluntary organisations such as the RNIB and the Macular Society. So now, as a non-ophthalmologist, you should be able to take a history for retinal disease, test the visual acuity, perform an Amsler test, and at least elicit the red reflex if you cannot see the retina with an ophthalmoscope. You know how to refer to an ophthalmologist and spell ophthalmology. You, of course, can always comfort your patient and signpost your patient to sources of support. And who knows, one day in the future, there will be retinal implants which will start to restore the sight of our completely blind patients with retinal disease. Thank you very much for your attention.